If you put a man in a dark room, then he will think dark thoughts. But if you put a man into an elite room, then he will think elite thoughts. Welcome to Elite Medical School, where today's subject is depression. We're going to examine our energy fields. We will be using our power and will to reduce our suffering. How's it going today, boys?
Yeah. It's going well, man. I think Dr. C's gone ahead and muted himself. Maybe because of uncontrollable sobbing, given that he's suffering a major depressive episode. Oh, he's back online.
Sorry, I'm just moving to a different location because it's just a little bit of noise here, so just bear with me for a second.
Doctor, I thank you so much for that introduction. I think I'm as excited as you are today to talk about major depression.
Oh, of course. This is not only important for your exams, because this is an extremely high yield topic. You're basically guaranteed to see some sort of mood disorder, but most likely depression on your exams. But it's also going to be wildly important to your practice. 10% lifetime prevalence of MDD in the general population. So you're certainly going to encounter these patients.
Absolutely. If not, your colleagues or you yourself might be afflicted. So listen closely. So why don't we just jump right into things? Dr. I, how might one define major depressive disorder, or what does a patient presentation look like? We're fortunate because Dr. C is afflicted with so many illnesses, with so many comorbidities, that we can basically use him as a patient presentation for the whole STI unit, most of the psychiatry unit. So what might Dr. C present to your ambulatory care clinic or your psychiatric clinic? How might he present?
If we go based on our classic Dsm-5 criteria, there's a few things that you will be looking out for. It's very important to memorize the criteria. It's a little monotonous, but you got to do what you got to do. And it is the following. So for a period of 2 weeks, there is a series of symptoms, and one of which has to be depressed mood or a loss of interest or pleasure in regular activities, which is known as anhedonia. The 9 symptoms that you should memorize can be, you should know the acronym MSIGI CAPS. So M for mood, we discussed, and then S is for sleep. So people will experience disturbed sleep, most likely early morning awakening or initial insomnia. So it's useful to ask individuals to record the number of hours, tell them exactly for them to tell you exactly how much they've been sleeping, characterize the number of nocturnal emissions.
Nocturnal emissions, absolutely.
Yeah. I is for interest, which is that lack of interest or anhedonia, as we discussed. And then G is for guilt. So usually surrounding some past misdeed, bit of an exaggerated response. So, if there's a lot of guilt about fapping the last day, they might be really distraught about it. Low energy, as opposed to like the high energy you would see with something like mania. People just don't have.
Or being like alpha.
Or yeah,
it's very much like a beta.
Yeah. Yeah, just think of the Chad versus the Virgin meme, and when you see the Virgin, that's your MSE for a depressed patient.
Right, it's just sort of a mnemonic device.
Yeah. We've also got impaired concentration. So typically what I like to ask patients is, when they're watching TV or reading a book, how well are they able to focus on that? Are they able to keep up with what's going on? Especially useful in the elderly. Appetite. That's a big one. That's A. It could be increased or decreased depending on how they're using food to cope. And P is for psychomotor retardation or potentially agitation, but most likely psychomotor retardation. they physically slow down, which is especially prevalent in like the severe subtype of the illness. And finally, we have suicidality. There is this risk of ideation and potentially acting on those thoughts. You should ask about it even if they don't mention it. This is also very key, very high yield for any exam or patient assessment. It will be necessary to assess their safety and whether they're safe to go home and what kind of activities have they been engaging in. Now, Dr. C, I'll ask you a common question. Does asking about suicidal ideation, does that increase the risk of suicide?
Does it increase the risk of suicide?
Yeah, like if I ask a depressed patient, "Are you feeling suicidal?" Is that going to provoke them in any way to put a gun in their mouth?
It's it's possible. I don't know any data on that. I would doubt it.
Yeah, so the data
I don't know if there's been studies on that.
Yeah, the data shows that there actually is not an increased risk of suicide by asking about that. And oftentimes patients will be thankful that you are the one that brought up the subject because it can be difficult to bring up on their own. So it's actually very useful to ask about it when you can. Do not be shy. Now, Dr. What are we going with?
You can call me whatever you want, baby. You can call me daddy. You can call me just whatever you like.
Dr. Shit. What was I going to ask? Oh yeah. This is like a pretty checklisty list that we have here. How would you go about asking these questions to make it seem like maybe more of a natural conversation?
Well, you might, practically speaking, actually get the patient to do it while they're on an iPad in the waiting room because you only have 15 minutes. But yeah, I mean, the alternative to that, would be to incorporate this sort of conversationally. I'm not sure if you're getting at some tool in particular, but rather than sort of, itemizing things, I think incorporating it conversationally is valuable so that you don't get sort of yes or no responses, and the patient may elaborate on their symptoms in a way that's more informative.
Yeah. I think one of the key ways of gathering this history is to use open-ended questions. How have they been dealing with their mood? Why exactly are they presenting to you then and there? And to not neglect the psychosocial aspect. So what has been going on in their lives, reviewing their medical history as well. On that note, what else would we be asking about in an interview for a depressed patient?
We spoke about.
I would imagine we would want to ask a lot about any substance use.
That's true. Substance use is very important. So, we want to consider kind of the illicit substances, including cannabis, alcohol, stimulants. We want to think about things like stimulant withdrawal. Basically, any sort of illicit substances will have some sort of impact on mood. But we also want to consider prescribed medications as well. So are they taking something like a beta blocker, or are they on benzos from their previous family doctor who prescribed it 2 milligrams Q4H for anxiety? What is it that they're taking, and how is that impacting their mood as well? Anything else we would want to ask about?
Yeah, so those comorbidities or other, the differential, and in terms of treatment, you may have to rule out things like manic symptoms. Some of our medications, like SSRIs, theoretically can unmask mania, so screening for that as well will be useful.
Yeah, that's a very good point. I would add with the anxiety also would be useful to assess for eating disorders as well. Now, I just realized that I didn't go through all of the DSM criteria. So the first part that I mentioned, the 5 out of 9 over the last 2 weeks, that's criteria A. B,